Hello and welcome everybody to this amazing recording focusing on familial chylomicronaemia syndrome. As part of the four kind of videos that we have created before the annual meeting, you will know that we are looking at navigating different conditions, their management, and in this case, navigating FCS or familial chylomicronemia syndrome, where management relies mostly on diet and lifestyle, but also looking at it from a patient and clinician's perspective. How do we manage these risks? And what is the future? What is on the horizon as far as treatment and management is concerned? This webinar is an extension of the impactful work that FHU Foundation has been doing in this space and will focus, as I said, on FCS, on the diet and the lifestyle, how to manage these conditions, how to help individuals manage, but also looking at the latest treatments, as we know there are developments on the horizon and what that would mean for our community. We are delighted to have an amazing panel of experts who will discuss how we manage living with FCS, what the diet plays a role, tips and tricks on how to manage it, but also some of the new treatments, as we said, that are on the horizon, and how this will impact our community, what it means for us at FH Foundation, Action FCS, but mainly for those people who are actually living with or caring for those who live with FCS. This is an introduction to the more in-depth conversations that we will be having at our FH Europe annual meeting, and I look forward to discussing this a bit more with you then. At FH Europe Foundation, we have a strong belief in education and that it will help support our community as well as those around us the more we raise awareness and understanding about the conditions that we live with. With this in mind, any links to webinars, information that we have shared previously, as well as what we are sharing in this recording, will be shared at the end of the discussion today. You will also be able to find it on our FH Europe Foundation YouTube channel, the website, and any of our social media outlets. We will include a link to the impactful work that is being done with the patient ambassadors, engagement with ad boards, the advocacy work that they are doing. We're in line with FCS Awareness Day coming up, our work and collaboration with Action FCS as well as FCS Foundation. We encourage you to take up the 10-gram fat challenge. It is one day where you will get a slight inkling into how these people have to manage. We encourage you to take up the 10-gram fat challenge. It is one day to raise awareness and educate yourself on how individuals living with FCS have to manage not just on an everyday, day-to-day basis, but social circumstances, going out to meetings, just general daily life. And we will continue to build on this momentum as we go through our awareness campaign. This recording will offer opportunity to our patient ambassadors to share their experience of living with and supporting those living with FCS and how to mitigate some of the risk factors that come with the condition, especially around diet and how to kind of manage not just your general everyday, but if you're going out or what are some of the tips and tricks that they've found. So thank you for joining us today, and let's delve deeper into how we can continue to transform the lives and pave the way for a healthier future. I would like to introduce to you in no particular order, Helga Davidson, FH Europe Foundation Ambassador and a member of Action FCS. She was diagnosed with FCS a few years ago after an incredible journey of diagnostic odyssey where she had to face tremendous medical concerns. A lot of people living with FCS go through very similar stories, so her story gives hope and encouragement for others facing the diagnosis and learning how to deal with it. She has turned her focus to raising awareness and educating others, but also, incredibly, is a member of FCS group and shares her knowledge and experience openly. And this makes the path a little easier and less stressful for some of the others. She has a background in engineering and studied nutrition and now brings her unique insights and lived experience to the discussion. I also like to introduce you to Antonio Gallo, Associated Professor of Medicine at Sorbonne University, working in the field of preventative cardiology and genetic dyslipidemia. He is part of one of the first centers of excellence that work in the field of genetic dyslipidemias and focuses on translational approaches to cardiovascular risk prediction. This is basically a long way of saying that he has a direct impact on our community. He's been an incredible part in helping us educate and raising awareness. from rare homozygous FH, where he collaborated with other ambassadors to ensure access to relevant treatment, but also areas such as Lp(a) and the related residual risk that people face. Today, we will engage him with the most rare of our conditions, familial chylomicronaemia syndrome, and how his centre is supporting those living with the condition, from diagnosis to raising awareness to delivering messages to these individuals and helping them manage their journey. So with that in mind, thank you everybody for joining us. And I'm going to ask for Helga to just briefly share her journey with FCS, take a few minutes. How did you become aware of the condition? How was it diagnosed? Some of the symptoms and the impact that it's had on your life, but also your family.
Yeah, well, despite having elevated triglycerides for a number of years, I was finally diagnosed when I had a severe acute pancreatic attack. I'd been to various different lipid clinics throughout my adult life, and it was only after that attack that when I went back to clinic, the physician decided to do a genetic test on me to see what was the underlying cause of my consistently high triglycerides. I'm grateful that she did it so that I could put a name to everything that I was going through, all my symptoms, abdominal pain. Also been diagnosed with fatty liver, which they couldn't find a root cause apart from the high triglycerides, which primarily was basically reflected back to me as being my fault through my lifestyle. But I tried to explain at the time, I didn't think my lifestyle was that bad. I didn't drink alcohol very much. I did regular exercise, and also, in my opinion, had a relatively good diet. I didn't eat a lot of processed foods. I tried to cook from scratch, but my triglycerides just kept on going up. It was only after, being at all these different clinics, trying to follow like low-fat diets, but the FCS diagnosis and realising the importance of maintaining that low-fat diet really had an impact on my health for the better. Because at the back of your mind, you also had the consistent sort of anxiety and stress of having yet another attack of pancreatitis, which is an extremely painful condition and it can be quite debilitating. That big attack that I spoke about prior to my diagnosis, I was in hospital for 6 weeks. And on the back of that, I also took sepsis. So it was quite a challenge to overcome that, and then also at the same time to be faced with being told I had this rare lipid condition. Trying to see the right people to get the right advice was non-existent. It was an uphill struggle. I was basically told, watch your fats, eat less than 20 grams of fat every day, and kind of left just to get on with it. Had a big impact mentally, I would say, because I had this underlying anxiety and stress about eating. And although I wouldn't say that it's developed into maybe like an eating disorder, I would say it's more like disordered eating. That in days where I don't feel the greatest, I do think, should I have something? Is it going to make me feel worse? So there's a lot of anxiety, primarily around food. But on the back of that, again, not getting the proper advice or what I thought was proper advice, I thought I need to help myself. So I went and I enrolled on a distance learning with Aberdeen University and did a partial degree on nutrition. And I think that has certainly helped me on my way to better health. It also affects relationships having FCS because socially it limits you. People invite you out to eat, which should be a nice thing in life, but for me with FCS, it's a source of stress. If I can't get a copy of the menu before I go to scrutinise it to see what I could possibly have to eat, people sometimes think you're awkward when you say you can't go, or if you contact a restaurant and you try and explain to them and see if they could bend the menu to suit you, you get labelled a fussy eater. You know, it's because people just don't understand the concept of what lipids in your blood can actually do to your body and the consequences of having really high triglycerides. Yeah, they know like cholesterol and heart attacks have got a correlation, but not all the things that FCS does to you. And having to constantly explain that to people, it is quite tiring. A lot of people think you hide behind it and use it as an excuse because you don't want to see them socially, which isn't the case. You want to get out there, but in society, so much is built around the narrative of going for a meal, going for drinks, which is another thing that an FCS patient can't do. We can't drink alcohol. Alcohol raises the triglycerides, and raised triglycerides causes a lot of illness symptoms. And it's not just a one-sided illness. It's not just a physical illness. It is definitely a psychological illness as well, with having all these other factors that can cause stress and anxiety, and the social burden of not being able to do what other people do.
Thank you, Helga. It is an incredible journey for people, especially when it comes around diet, because it's very easy, or it seems a lot easier when you're actually allergic to something, to just go, I can't have it because I'm allergic.
Yeah.
When they now say to you, is it allergies? And you go, well, no, it's not allergies, because you're trying to be honest about it, and then you still kind of get put on the back foot about it. So FCS, if you had to explain to somebody in normal terms, familial chylomicronemia syndrome is a mouthful, what would you say if somebody asked you what it is?
Someone asks me what FCS is, I say to them it's a rare inherited genetic condition, which means, in layman terms, my blood holds on to triglycerides longer than what it should, and a thing called chylomicrons, which nobody's ever heard of. Having too many of them in the blood causes me to have abdominal pain. It puts me at risk of having pancreatitis, because most of my friends remember how ill I was with the pancreatitis. So the only way that I can control this is by what I put in my mouth. So I have to be very strict on my diet so that I don't present again with a serious bout of pancreatitis. But again, pancreatitis is also quite a unknown thing to people. They always think the pancreas is just related, it's there just for pumping out insulin.
It's a complicated system to try and explain at the best of times, I think. And so the awareness campaigns that we're doing, I think, is very important, and making sure that people are up to date with that.
Through the injury to my pancreas, I also have to use PERT therapy, which is to replace the digestive enzymes which my pancreas no longer produces. So you've got to explain that aspect as well to people, that I need to take these tablets in order to digest food.
It gets really complicated because although it's the whole condition, it's actually the symptoms that are sometimes more difficult to manage, especially because although there's new treatments on the horizon now, before it wasn't. It was all about how you manage the symptoms. With that in mind, I'd like to invite Antonia to possibly come in and tell us a bit more about FCS, what it is, and what is the management at the moment, what is the treatments that we see in the future.
Thank you very much, first of all, for this invitation. It's very nice to be among you to discuss about this very rare disease. So first of all, FCS, familial chylomicronemia syndrome, is a very rare disease. It's estimated to be involving one patient over 1 million, but probably this is an underestimation of the prevalence of this disease, which is inherited in a way that is not possible to find in all generations across the family. which means that the parents of a patient with FCS wouldn't have any sign of disease. It's a disease that is associated with a defective enzyme that is called lipoprotein lipase, which is supposed to metabolize triglycerides. So to take out triglycerides from the blood and to stock them in the peripheral tissues, in other tissues in our body, because being fat, they are our stock of energy. What happens in FCS is that this lipoprotein lipase doesn't work well because of some genetic defects. And triglycerides, as a result, stay very high in blood. These triglycerides are called chylomicrons, and this is quite a difference from the other particles that are also rich in triglycerides, but that are not chylomicrons because they already start containing some cholesterol. What are chylomicrons? That are some lipoproteins, so some transporters of fat that are actually full of triglycerides. So they only have triglycerides. They are pretty large, and for this reason, they do not enter the vessel wall. They do not enter the arteries, and so they are not atherogenic, so they do not cause cardiovascular disease. But as they are very fat and very big, they make the blood pretty viscous, pretty thick. And this is one of the reasons why patients living with FCS can experience acute pancreatitis. So acute pancreatitis is the main complication of this disease. And when we have pancreatitis that are associated to high triglycerides, this pancreatitis seems to be more severe, meaning that the risk of complications, as Helga was suggesting, the risk of complication of these events might be higher than when pancreatitis is related to other causes. What has been the main challenge up till now in managing FCS is that the treatments that we had available were really not sufficient, not enough, and not efficacious at all in correcting this hypertriglyceridemia. So patients would be still exposed to extremely high levels of triglycerides despite the treatment that would be completely inappropriate. Before talking about the management, if I can just maybe say one thing, because as you were suggesting, the diagnosis is pretty much delayed in patients living with FCS because it's not really well known even among the medical community, being a very rare disease. There is also a misknowledge of what triglycerides are, because we usually talk about cholesterol when it's about lipids. And so we do not quite get it what triglycerides are and what do they depend on in terms of diet. One of the symptoms that could alert the practitioners is not only the event of acute pancreatitis, but also the fact that patients might have some quite recurrent abdominal pains after meals that could be more or less charged in fat or sugar. This is difficult to estimate because it's not a matter of quality, it's most of all a matter of quantity, which is a bit sad to say, but it's the reality. And when there is no response to treatment, but also no other secondary causes, because usually diabetes or alcohol consumption that might be associated with secondary hypertriglyceridemia are not present. And so patients are usually free from any other disease, any other condition. So the big new is that since a few years, some mechanisms have been found that can counteract this defect in the lipoprotein lipase action. And one of the actors of this mechanism is ApoC3. ApoC3 is a protein that goes to inhibit lipoprotein lipase, but that also works independently from lipoprotein lipase. And if we block this enzyme, we can actually significantly lower triglycerides. So there has been quite a significant pharmacological development recently, and there are 3 main treatments that are now available for the management of FCS that have been tested in patients living with FCS, but also with multifactorial chylomicronemia syndromes, which is not necessarily as strictly related to a genetic defect, and that work very well in decreasing triglyceride levels by 50 to 70 or even more percent. So it's a significant reduction in triglycerides levels that has been associated mostly with the new generation treatments, so olezarsen and plozasiran, associated with a reduction in the incidence of acute pancreatitis. So what we couldn't observe with the first treatments was the reduction in events, despite a significant reduction in triglycerides. Now we can finally see that patients being treated with these new treatments can finally reduce the risk of having acute pancreatitis. So there is a changing landscape in the management of this disease that was also characterized by one major unmet need, that was the treatment, but that led patients to get away from the centers. So we used to have a lot of patients that would get lost in their follow-up. We couldn't manage to follow up patients and to see them regularly, frequently, because there was no option. So they would kind of run away, which I can somehow also understand. So things are changing, but now a lot of education is needed also to patients in order to kind of come back and understand that the natural history of this disease might quite change in the next years and hopefully for the future.
That's brilliant. And actually, coming back to natural history and kind of part of that diagnosis, as you said, it's quite often the diagnosis would have worked really well if somebody picked up abdominal pain and that kind of thing earlier. So, Helga, what were some of the first symptoms that you had, and were they picked up at all?
I would say, looking back, my first symptoms was as a child. I used to suffer quite a lot with vomiting episodes, abdominal pain. I used to also have quite a lot of cramping in my muscles, headaches. I was always quite tired as well. And the abdominal pain and the vomiting, I did see a doctor with regards to that, and the diagnosis was I had a nervous stomach. The cramping in my legs was put down to growing pains. I was often accused of not wanting to go to school and putting on that I had pains in my tummy. But probably the earliest proper clinical symptom that appeared would have been my fatty liver. And from that, also the high level of triglycerides in my blood. But that was probably 15, 20 years before I got my proper diagnosis. And I've seen a lot of different doctors before that came around.
And I think that leads in really well. So, Antonia, I mean, that concept of people not understanding the condition, and before, because there was no treatment option, it might have been that they didn't actually they spent more time on the symptoms and making sure the diet was correct. Do you see that changes with clinicians and understanding the condition better and being able to identify it earlier?
Well, we are maybe slightly more used nowadays to go for a blood sampling, which is the easiest way to just detect this kind of anomalies. And definitely gastrointestinal symptoms, abdominal pain in a child it's very unspecific. So it might, let you check for plenty of other things, but at least actually having a the reflect of making a simple blood test for lipid testing could indeed help resolve the diagnosis much easier. Sometimes there are also some septic events, infections in children that lead then to the discovery of the disease. So it's still quite erratic. I don't know if it's the word. It's still quite random. Let's say the way the diagnosis is actually made, even in children, because it's still a very rare disease, and there is need for more knowledge.
As you say, it's quite erratic to find the doctor that actually knows it. I heard of a very good story where somebody in A&E was taking blood, and she realised the separation of the blood, because it's very visual actually when somebody with FCS has actually taken blood, and that's how she kind of went, this isn't right, and it was actually dark, and she switched on the light thinking that she had done the wrong test or got the blood from the wrong area. So it was by accident, and unfortunately a lot of diagnosis, speaking to Helga and some of the others, it is generally by accident. So when we're thinking about screening, so we know that newborn screening, early detection screening is all a big thing at the moment that lots of people are talking about. How does genetic testing work for diagnosing FCS, and who should actually be having that?
This is a challenging question. Not easy to answer that, because when we talk about screening, of course, we would like to have it more, extended. So there might be countries where there are some, not genome-wide, but very enlarged, genome-wide, I would say, testings at birth that might be done. And for certain specific conditions like familial chylomicronemia syndrome, I think that there is really an interest in, putting some target genes in the list for screening in order to really prevent and to really overcome the these delays in diagnosis. I strongly believe there is an interest in doing this because of the difficulties in making diagnosis. The other point is who could benefit from the genetic testing? Well, let's say that when we do the genetic test, the interpretation of the genetic test might be also a bit challenging, because the genetics of hypertriglyceridemia are pretty complex. We have 5 main genes that are the main candidates, and for which we look for, let's say, mutations for which a dysfunction has been associated, but there are a lot of variants, like a lot of polymorphisms that can predispose, but that they are not causally associated with the disease, though they do not allow us to really conclude on a definite diagnosis. So it's also there is a lot to do, and there's a lot of work going on, to be honest, on this topic, in order for it to be a bit more precise.
There is, so I know in the UK it's part of one of their pilot projects, and FCS and homozygous FH are both on the list, so it'll be interesting to see how that develops. But Helga, from a patient's point of view, how important was it to get that genetic? First of all, did you get a genetic test, and how important was it to have that diagnosis and that test done?
It was through a genetic test that I got my diagnosis. And for me, it was important because I could put a name to what was wrong with me. Because you do reach a point where you think, is all this in my head? Because no one can give it a name to it. But then having that name, it doesn't change your diagnosis, it doesn't change your symptoms, but it does make you feel better that you know that there is actually a physical reason why you feel how you feel. So yeah, it was very important for me to be able to put a name to it, and that happened through the genetic test.
So that follows on. Oh, carry on.
Sorry, no, I just really wanted to react to that because I really strongly believe that this is one of the main reasons also for which genetic testing really helps in also setting a dialogue with the doctors between, I mean, doctors and patients, because it first of all takes out all the guilty. Like, this is not your fault. This is just a genetic condition, and you were born with this, and this is not about, stigmatization about alcohol consumption, etc. It's something also that could help eventually patients to also talk about this disease with because sometimes there is some shame. I don't know, if this was your case, but sometimes I see with some of my patients, there is some shame of declaring your condition in your with the people that you're surrounded by, and there is a lot of meaning that goes just beyond the genetics itself, and also with commitment to diet and eventually treatments. It gets you to a whole another vision of the management of this condition.
It makes it very different, I think, if you can kind of draw that line between what is something that I've done to myself and actually what is something that I have to manage, because it is part of who I am. I think, I don't know, Helga, obviously, when you were diagnosed, you had to make a lot of changes. So if you had somebody who was newly diagnosed, what would be some of your kind of top tips that you would give them? What would be the advice?
I would say in this situation, one of the most beneficial things that you can do is first and foremost ask your clinician as many questions as you can. But for dietary advice, track your fats, all fats, and make sure that you're eating as low as you can, because that is the key. That and complex carbohydrates. I found for me that those two things, keeping a track on them, has kept me in relatively good health since my diagnosis.
And so that leads me nicely on to, again, Antonio. So if you had a patient that came to your clinic and it's a new diagnosis of FCS, what would be some of those conversations, and where would you kind of direct them to get more information from?
So the announcement of a disease is never easy for the doctor to do it, and for the patient to get it. So it's not something that can happen in one shot. There is a moment when some silence is needed. We need to metabolize, we need to integrate the new, and we need to get another moment to talk about it. So there are some, in France at least, we have some educational programs that might help come back to the clinic and discuss in our all different setting, like where I don't have my white coat, and we just talk independently from the clinical setting about a lot of things that turn around the how you live with the disease. How does this impact your daily life? And then, of course, we get through the topics of diet and physical activity and all the other possible counseling that we can get to. And this is something that necessarily requires time, but also requires awareness in terms of the importance and of the impact that just following a strict diet can have on the control of the disease. So it's something that we do in several steps. And but first of all, we need to deliver some information, and we need to get sure that there is a possibility to track the fat consumption. So there is always a dietitian that is like a binôme with the clinician, and that follows the patients quite closely in order to really discuss and exchange continuously on the least practical questions that the patient might have.
Oh, that's excellent. And I like the idea of that because sometimes the diagnosis is delivered so quickly that you don't have time to actually process it. And it's, as Helga said, you know, you want to ask lots of questions, but in that moment, that's really tricky. Helga, would you have any kind of tips of how somebody can, because you've been through that way, you've been delivered the diagnosis, how can you make it easier to metabolize and think about the condition and what questions to ask, because in that moment I'm sure that that's not really the best time.
Yeah, I mean, one of the biggest issues that I faced was that they could all tell me what I shouldn't be eating, but no one was able to say you should be eating this for optimal health. So hence the reason I ended up looking into nutrition myself. So I would just chip away constantly and just say, you know, if I eat this or if I go over that, what's going to be the consequences of that to my health? If I stick rigidly to the diet, what are my chances of having like another episode of pancreatitis? What levels do my triglycerides need to be at in order to do away with the worry about having pancreatitis? You know, there's so many questions that I didn't get to ask at the time because, as I said, I was told eat less than 20 grams of fat a day and kind of left to go on with it. Even recently, after a visit to my consultant, and I asked again to be referred back to the dietitian just for a chat about my diet to make sure that everything was as it should be. I think I shared the email with you. She came back and she said to me during the consultation, you know, I was eating too little fat. And I said to her about the condition, about my advice from the consultant. And she said, well, I'll need to look into that. So she wasn't fully aware either. So I think we need to get people that know about the condition that can answer those questions, because you could ask all the questions you like, but if you don't get the proper answers, it doesn't matter.
Here's a question that wasn't on our list, so I apologize. But Antonio, so part of France's way of dealing with things, they have these centers of excellence. Within the France's concept of having these specialist centers, would you have that continuation of a dietitian plus a doctor plus a genetic counselor, all kind of working with the journey?
So it's a work in progress, let's say, because in this recent network of referral centers, we try to have and to train actually dietitians, and we try to have genetic counselors for a proper counseling, also family planning. Discussions for women living with FCS, and we try to have a multidisciplinary approach. I'm also, for example, like struggling to have a psychologist that could also accompany patients, but this is something that depends on the hospitals, on the availabilities of these figures. But this is definitely priority to have a multidisciplinary support for patients.
So speaking of that, we know that it is different in different places. And I've just spent a few months in South Africa where I found that the activities are very different to somebody in Europe. So Helga, you probably know some of the difficulties just managing symptoms sometimes with the diet, how it would be different. And maybe Antonio, you can as well. How would it look if I was somebody in my early 20s, diagnosed with FCS in the UK, where there is an organization that supports, so they could point me in that direction, to maybe somebody in Romania, or maybe where some of the other patient advocates are, where it's not as easy. Is there a way that we could support some of these patients in getting access to things? From a patient point of view, what would you suggest for them, and as well from a clinician?
From a patient point of view, I can say hand on heart that most of the support and information that I got about FCS was from Jill and Action FCS, because the consultants, the one that diagnosed me, she retired, and I got a new doctor who, whilst he was a lipid expert, wasn't that up to scratch about FCS. So, I mean, sometimes the people that have lived with the condition can gain more information and give you more information than the doctors that you're seeing. You know, just through the experience that they have, you know, they can give you like the little tips. So I was feeling really ill, and, you know, I tried this and it helped, or I was at the supermarket and I found this product and it's really low in fat and you might try that, you know, to boost your diet. So I would say for a newly diagnosed person, to get support on as many fronts as you can. And sometimes as well, you know, you can be a bit in awe of your doctor, you know, and you don't want to ask the questions, or you feel that you're taking up too much of their time and there's other people that they want to see. Whereas if you're in your peer group of other patients, you're more likely to be open and ask more questions. So definitely find a patient-centred group of support as well as the clinical staff support.
I couldn't agree more, because actually the only thing that I was thinking about now is about a patient that has been going through tens of pancreatitis, and I managed to see just a few weeks ago. It comes from a country where there is not a network, when there is not that much knowledge about the disease. So there has been 30 years of misdiagnosis. Actually, I mean, he was just not even aware. And the big power that there is nowadays is like social media and, you know, networks that can really help patients look for information, because education is key for patients. First of all, experiencing symptoms, understanding what they are related to, and then for patients also getting to educate their own general practitioners, because education really needs to go both ways. And if you know more because you have found this network and you get proper information, then just do not hesitate to go tell your doctor that this is probably what you have, or at least just please check, be sensitive to this, and tell me if that can correspond to what I am experiencing, to the symptoms that I have. Just go make your, you know, researches and come back to me to tell me if this might be clinically associated, and then we can look for you know, referral centers and etc. But it comes back to the territory, to what's happening, to what happens in the in the real context.
That real world is a big difference. But I want to thank you both. This has been incredible talking, and we could probably talk for another few hours on the various things that we can go into. And when we see you at the annual meeting, I'm sure we will catch up on a few more bits. But before we go, I have two more questions for each of you. One is, we've spoken about some of the difficulties that's happened, but we've also spoken about the silver lining and these new management that's coming, you know, that's on the kind of horizon. What would be your kind of key takeaway for somebody that is maybe newly diagnosed, and what would be your message to encourage them to actually look at how to manage their system and how to get involved?
So the key message for me would be, okay, this is a rare disease. This is a disease that can be controlled, and the control of this disease will mostly rely on diet, so on the way you manage to approach diet. But there are a lot of, the landscape is changing, and there are a lot of treatments that can help you control this disease and prevent or avoid the complications that are related to this disease. So we can work together in order to really change the landscape and ameliorate the management of this condition.
Helga?
Yeah, with the new treatments that are coming through, haven't read a bit about them. I would say, you know, don't be scared to try them, because they will treat the underlying disease, which in turn will help with your symptoms and give you a nicer life. So just follow on from the advice and try them. Don't be scared. If it doesn't work for you, you stop taking them. But you have to give things a go. That, together with your diet and exercise, could lead you to having a fairly normal life.
That's brilliant. And for the last plug it is our FCS Awareness Day coming up on the 1st of November, where we can definitely make sure that we educate and we let as many people know as we can. So there will be a social media campaign. And I believe, Antonio, you've already been told that your photo is on your way for you to share on social media. Helga, I've already seen your photo, so that we know that it's there already. So a final message to encourage people to try it out for a day. If we start with Helga.
I don't think people realise what 10 grams of fat in food looks like. And I think it would be a very good educational activity for them to take part in. And it's for fun as well, you know, so give it your best.
And then
Yes, I think it's a challenge that everyone should try at least once in his life, because it's very interesting to realize on how much fat we might consume and introduce every day in our body. But at the same time, we can easily also find alternatives, and so we can also manage to get some very interesting, healthy, and pretty delicious alternatives. So I'm looking forward to this challenge on the 1st of November.
And on that note, it'll be amazing. So please share any of your kind of alternatives that you can find, so that we can make sure that we get people's diets a bit more richer. But again, thank you very much for both of you for joining us. And we will share any of the links to the patient organizations, as well as papers that we've discussed, and the new treatment management that is coming up as well. And that's brilliant. Thank you.
Thank you
care,
very
guys.
much.
Bye.
Bye.